Good evening, everyone. Welcome. Thanks so much for joining us for this virtual UMiami Health Talk, your guide in treating atrial fibrillation or AFib. Thanks so much for so many of you joining us despite the stormy weather out here tonight. I'm health journalist Ileana Bravo. I'm going to be your moderator for this evening's talk, which is presented by the University of Miami Health System Cardiac and Vascular Division. UHealth's cardiovascular experts pioneer and advance the latest diagnostic and surgical procedures. Did you know that UHealth has one of the only comprehensive atrial fibrillation risk factor management programs in all of Florida? Our Center for AFib is a leader in research related to diagnosis and treatment with funding from the National Institutes of Health and other private and industry sources. As an academic-based heart center, they offer patients a unique multidisciplinary approach that includes the most advanced therapies available, combined with lifestyle modification to achieve the most effective control of AFib. We invite you to learn more about UHealth's cardiovascular department by visiting uhealthcv.com and to schedule a consultation and screening, call 305-243-5554. Don't worry, we're going to repeat that information again before the end of this talk, which is being recorded, by the way, and you will get a link to the recording later on. So I just want you to know that tonight you're going to hear from cardiovascular expert Dr. Jeffrey Goldberger, who will explore the following topics. What are the risk factors for atrial fibrillation? Managing your AFib. What will Ozempic do for my atrial fibrillation? And atrial fibrillation therapy in 2023 and its future. At the end of this evening's presentation, you will have the opportunity to enter into a Q&A session with Dr. Goldberger so he can address your questions. It's a very unique opportunity with our expert tonight. So please use the anonymous Q&A feature at the bottom of your Zoom screen. Take a moment to locate it now. We all have different devices we're coming from, so see where yours is. And you can enter the questions as you think of them. We will prepare them so our expert can address them at the end of the presentation. So now it's my pleasure to introduce our expert, Dr. Jeffrey Goldberger. He is the director of the Center for Atrial Fibrillation at the University of Miami Health System and an esteemed professor of medicine at the Miller School of Medicine. He's a leading authority in cardiac arrhythmias and autonomic nervous system effects on cardiac electrophysiology. Dr. Goldberger has led several clinical trials, and his research has focused on innovative diagnostic and treatment approaches for patients with arrhythmias, particularly atrial fibrillation, and prevention of sudden cardiac death. It is now my pleasure to welcome Dr. Goldberger on your screen. You probably need to unmute and join us, Dr. Goldberger. Okay, it'll be just a moment. Dr. Goldberger, are you with us?
Hey, I'm here. Thank you, Ileana. Can you see my screen?
Yes, I think you need to get into presenter mode and then it'll be perfect, right?
Okay, I am in presenter mode, but let me...
Yeah, there. Well, now we lost it for a moment, but the good news is we have a lot of people here who are excited to hear this information. They all tuned in so quickly. So let's just take a quick second to get our ducks in a row. There we go. Is that presenter mode? There we go. Awesome.
Okay, Ileana, thank you so much. I'm really delighted to be here with all of you in honor of National Atrial Fibrillation Awareness Month. And hope we'll have a wonderful discussion about atrial fibrillation. My talk this evening is entitled Personalized Approach to Atrial Fibrillation, the Physician-Patient Partnership. Our goals for this evening are to review how atrial fibrillation, and because it's so hard to say atrial fibrillation, we'll stick to AFib. It's a complex disease, and there are many different approaches that we'll touch on, but I really want to touch on the importance of the patient in controlling atrial fibrillation, patient participation. We'll touch on some of the current challenges in AFib and what some of the future approaches are to help address those challenges for atrial fibrillation. So the first question we need to address is, what is atrial fibrillation? So I have here a multimedia demonstration to help us understand. Everybody can formulate what the best way is for them to understand atrial fibrillation. But down here, this is an ultrasound or an echocardiogram picture of the heart. Everybody knows the heart has 4 chambers. The 2 main pumping chambers are called the ventricles, and those are shown here. The 2 top chambers are called the atria. So everything here is inverted. So the top chambers are shown at the bottom, and the bottom chambers are shown at the top. And the left atrium is shown on the right, and the right atrium is shown on the left. But that's the way the echocardiographers look at this. And you can see here, this is now the heart beating in the echocardiogram. And the heart beats in a very rhythmic fashion. First, the upper chambers beat, and then the lower chambers beat. And what drives the heart to beat is its own electrical system. And you can see that down here, the EKG. So now we'll stop this for a minute, and we'll go and look at the EKG, which is shown up here. So this is a normal EKG. And remember, we say the upper chambers beat first, and they generate this signal on the EKG called the P wave. The signal that's generated by the lower chambers, which are the main pumping chambers, chambers are much larger than the atria. So they generate a much larger signal, and that signal is called the QRS complex. And then they generate another signal called the T wave. But basically, this comes from the upper chamber, this comes from the lower chamber. And you can see in this normal tracing here, every beat has a P wave followed by QRS, P wave, QRS, P wave, QRS. And that is what results in this rhythmic beating of the heart, upper chambers contracting and then lower chambers contracting. Down here is a tracing from a patient with atrial fibrillation. And you'll see a couple of important differences between this tracing and this tracing. First of all, there's no discrete P wave. You can see there are a bunch of wavy lines that persist throughout this tracing, but no discrete P wave in front of every QRS complex. You'll also notice that the QRS complexes appear here in a very irregular fashion. Sometimes there's a long interval, sometimes there's a short interval, here's a long interval, and here you can see that it's fairly regular. So this is the hallmark of atrial fibrillation. It's a very irregular rhythm with no P waves. You have very erratic activation. And now I'll show you what that might look like. This is a model, so we're going to look at a simulation here of normal conduction. So you'll see first, when I start this movie, you'll see one normal beat where you see consistent propagation of this red impulse throughout this sheet. And then you'll see the initiation of atrial fibrillation, and you'll see how chaotic the rhythm it looks. So that's a normal beat, normal propagation. And now you see onset of atrial fibrillation, which is very disorganized. And it's this disorganization that leads to this wavy baseline that you see here on the ECG. So I hope this helps us to understand atrial fibrillation a little bit. And what I want you to also keep in mind is this disorganized activation of the atria leads to its inability to contract normally, like it does here. When you have a normal activation, the top chambers can contract. But when you have this abnormal activation like this, the upper chambers don't contract. And that will have implications for one of the main complications of atrial fibrillation, which is stroke. So atrial fibrillation is very, very common. We'll go through some of the total numbers in a few slides. But you can see it's a disease that begins to strike people usually at age 40, but there's a sharp increase at around age 60 with a peak incidence in the 70s. So it's very common to develop as people get older. And what's really important, I think most people want to know, well, what's my risk of getting atrial fibrillation? And this comes from a study done by a friend and colleague of mine, Don Lloyd-Jones. And he asked that very same question. He said, how do I tell somebody what's their lifetime risk for developing atrial fibrillation? So we'll look at here just for men at the beginning. And what you see is these lines are basically your risk of developing atrial fibrillation. If you reach age 40 and you have not had atrial fibrillation yet, This red line charts what your lifetime risk is of atrial fibrillation. If you got to age 50 and you didn't have atrial fibrillation yet, what's your lifetime risk of developing atrial fibrillation? And et cetera, age 60, age 70, age 80. And you can see all of these curves end up somewhere between 23 and 25%. So no matter what age you are, if you haven't yet had atrial fibrillation, you have about a 25% chance of developing atrial fibrillation during your lifetime. And the same is true for women. It's no less. It's about 23%. So that means 1 out of every 4 of us are going to develop atrial fibrillation during our lifetime. So that means either you, a spouse, a parent, a sibling, certainly many friends will develop atrial fibrillation. So this is something that we all need to know about. So what are the issues that we're concerned about with atrial fibrillation? So first of all, obviously, people are concerned about the symptoms that they're going to get with atrial fibrillation. And we'll talk about some of those in a few slides. The other very important thing is there's a risk of stroke with atrial fibrillation. And that has to do with the fact those atria don't contract normally. And when the atria don't contract, blood doesn't move normally. And when blood doesn't move normally, it clots. And if those blood clots travel to the brain, they can cause a stroke. Then the other important item that we get concerned about is what are the long-term outcomes? What's the implications of having atrial fibrillation? And it turns out that patients with atrial fibrillation don't live as long as patients without atrial fibrillation. And those are the 3 main things that we have to consider. This comes from a slide that we published a few years ago to describe why people get atrial fibrillation. So clearly, when somebody develops atrial fibrillation, it's not a disease that developed on that one day. There's a whole timeline of progression of disease in the atria that occurs perhaps over years that ultimately leads to this atrial fibrillation. And for our purposes, we want to understand what are those mediators, what leads to the developing the disease, the fibrosis, that leads to atrial fibrillation. Certainly aging can be that, the fat tissue around the heart, inflammation, variety of different pressure and volume issues related to the heart. All these things lead to fibrosis and ultimately development of what we call the substrate for atrial fibrillation. So we have to be cognizant of that so that we can understand how best to treat atrial fibrillation. So from a patient perspective, we want to talk about what are the modifiable risk factors for atrial fibrillation. Obviously, we can't modify aging. We hope that we are all going to age. But there are some things that we can modify both to prevent atrial fibrillation and even once we've developed atrial fibrillation. These are risk factors that can be used to control atrial fibrillation. And they're listed here: weight management, so controlling weight, physical fitness, high cholesterol, sleep apnea, high blood pressure, diabetes, smoking, alcohol. So these are things that if we can control them well, we can actually help outcomes with atrial fibrillation. And I'll show you some data and information about that. Now, there's a whole potpourri of therapies that can be used for atrial fibrillation. We're not going to be able to cover all of these, but I'll just mention them very quickly. So first of all, observation. It's not necessary that you have to do anything to treat atrial fibrillation. Depends on the clinical situation. Certainly, risk factor modification is something that we just discussed, can be helpful in controlling atrial fibrillation. There are a variety of medications that can be used. There's a procedure called catheter ablation, in which we put catheters through the blood vessels into the heart, and we burn selective areas to try to treat the atrial fibrillation. And this ablation can also be done surgically, but that does require an open chest procedure. For stroke prevention, same thing. Sometimes we don't have to do anything except observe. Sometimes we use blood thinners or anticoagulants, and sometimes we use devices that close off the area that is most likely the cause of stroke. So there are a lot of treatments. How do we pick a treatment? Is there a single best treatment? And I think this slide is meant to show you the complexity of the choices that we have in atrial fibrillation. So first of all, we have to assess what are the underlying problems that occur in a patient. Could be that you have atrial fibrillation in somebody who has no heart disease and no risk factors. Or patient could have just risk factors and no heart disease. Or they can have heart disease or severe heart disease like heart failure. Any of these possibilities can be associated with atrial fibrillation. There are also different types of atrial fibrillation. There's atrial fibrillation that comes and goes on its own, and that's called paroxysmal. There's atrial fibrillation that comes, and when it's there, if you don't do anything about it, it stays, and that's called persistent. And then sometimes people live with atrial fibrillation. It's there, and it's there permanently, and there's nothing to do about it. So you can see there are a lot of different types of atrial fibrillation. We also need to assess the symptoms that are associated with atrial fibrillation. Sometimes patients have no symptoms at all, and atrial fibrillation is just found serendipitously. Sometimes they just have mild palpitations, shortness of breath, lightheadedness, inability to exercise like they used to, or they can have severe symptoms like heart failure symptoms. So we have to assess all of these factors. And then once we assess all these factors and have our important discussions with our patient, then we have to try to match the best treatment to the variety of different disease processes that are ongoing. And again, we have these different treatment options that we can choose from. So I think at this point, it's useful to look at the how we make decisions between the physician and the patient. Now, obviously, there are situations where there's unilateral decision-making. I mean, for example, patient comes to a doctor with a sore throat and they do a strep test, it comes out positive. Doctor says, here's penicillin, and everybody's happy. The patient goes home and in a few days is better. There's also what I would call bilateral decision-making. You know, sometimes patients come to you and they're very informed by either other patients, the internet, and they have a sense of what they want to do. And then sometimes the doctors that they see also have a sense of what they want to do, but don't have a meeting of the minds on how to move forward. They each have their own sense of what to do. I think the best approach when it comes to atrial fibrillation, because there are so many factors here and it is a complex process, is what I would call the shared decision-making process, where the patient and the physician can look at all of the information we discussed on the last slide and decide what are the best treatments. And again, this can be a progressive process, right? You can try one thing, and if that doesn't work, one can go on to another treatment. It doesn't have to be all or none. And there are some treatments that the physician is going to initiate, but I think it's very important for us to discuss the patient treatments. What are the treatments that the patient is going to be involved with? And this can have very, very dramatic impact on outcomes for atrial fibrillation. I'd like to spend a few minutes talking about that because the patient responsibility for helping control atrial fibrillation is really paramount. So some of the first studies that assessed the importance of the patient component here came from Australia. And this is a study that was published in 2013, so about 10 years ago, where they looked at 150 patients with atrial fibrillation who were overweight with a body mass index over 27, and they had symptomatic atrial fibrillation. They randomized the patients into two treatment groups. One was an intervention group, which was basically a physician-led weight loss program. And the second group, the control group, was a self-directed general lifestyle measures. So this is basically the physician telling the patient, you're overweight, you need to lose weight, please go figure it out on your own. Now, it will not be surprising to anybody that those patients that were in the intervention group, now here we're looking at waist circumference over 15 months. So waist circumference dropped dramatically more in the patients that had a physician-guided program than those that were treated on their own. Same thing when we look at BMI. You have almost triple the results in the physician-led program than you do in the control group, where it's just the patients doing it on their own. So this shows the importance of the physician guiding, but also shows the importance of the patient participation. So what happened to their atrial fibrillation? So they looked at two things. They looked at what we call the symptom burden score and the symptom severity score. And once again, when one looks at the symptom burden score or the symptom severity score, one sees exactly the same thing. There's a dramatic improvement in the physician-led weight loss program compared to the patient-led weight loss program. So this shows the importance of weight loss and how it impacts atrial fibrillation. This study, also reported from the same group in Australia, now looks at the total survival free of atrial fibrillation using a variety of treatments. And this is an observational study. And they broke these patients up into 3 groups. Those that lost 3% of their weight in the purple, those that lost 3 to 9% of their weight, and those that lost 10% or more of their weight. And this is now follow-up over 5 years. And you can see that now looking here, this is freedom from atrial fibrillation. So the more decline here, it means the higher recurrence rate of atrial fibrillation. So here you could see 60% of patients had recurrent atrial fibrillation if they didn't lose weight. If they lost 3 to 9%, about 35% had recurrent atrial fibrillation. And if they lost more than 10%, only 15% had recurrent atrial fibrillation. So again, you see dramatic improvement in the treatment of atrial fibrillation with the medications and the ablation, depending on how much weight loss the patient achieves. So again, underlying the role of weight control in patients with atrial fibrillation. So I'd like to just summarize the statistics that we have for atrial fibrillation. So first, we said there's a lifetime risk of approximately 25%. Atrial fibrillation affects 5 million Americans and is going to affect over 12 million by 2050. 15% of strokes in the United States are attributable to atrial fibrillation. Although catheter ablation is a very good procedure for atrial fibrillation, success rate is only about 50%. So we have to think about ways to make that better. And I showed you now that risk factor modification in Australia has been very effective. So this really inspired us to try to figure out how we can apply risk factor modification in our population and how we can even make it even more effective. So we're still in the midst of this study called the LEAF study, liraglutide effects on atrial fibrillation. So liraglutide is also called Victoza. This is a medication that's very similar to Ozempic or Wegovy. It has the same kind of effect. But in this study, we took patients who were planning to have atrial fibrillation ablation. Most of them had persistent atrial fibrillation, and again, had body mass indexes above 27. And they got randomized to one of 2 treatment arms. One was standard risk factor modification, as was done in Australia, or risk factor modification plus liraglutide. And you can see that the patients in our study were actually quite heavy. So although the BMI requirement was over 27, the average BMI was about 36. So that corresponds to a weight of about 106 kilograms or 240 pounds. And we also divided up our patients, those that had less than 3% weight loss before the ablation, and those that had more than 3% weight loss before the ablation. You can see here that both treatment groups lost weight. There was a little bit more weight loss in the treatment, in the risk factor modification and liraglutide treatment group than in just the risk factor modification group. But we actually did see good weight loss in both groups. And the findings are really pretty striking. So we're just going to focus down here, what happens 6 months after ablation. So the black here shows freedom from atrial fibrillation. So these are people who have successful ablations, no atrial fibrillation, no antiarrhythmic drugs. 61% if you have less than 3% weight loss. But if you have 3% or more weight loss, it's up to 88%. And what happens if we look out to a year? So the numbers are smaller, but you can see if you look out to a year, those that have less than 3% weight loss have 42% success for their atrial fibrillation ablation. Whereas if you lose more than 3% of your weight, it's up to 81%. So that's almost a doubling of the benefit of ablation with this kind of weight loss. So again, this underlies the importance of the patient role in helping to control the atrial fibrillation. To give you a really striking example, I'll tell you about one of our patients who's a 60-year-old gentleman who had high blood pressure, coronary artery disease, and high cholesterol. We first saw him in 2019 with persistent atrial fibrillation. He got a cardioversion or a zapping procedure for his atrial fibrillation in February 2019. His atrial fibrillation recurred, and in June 2019, he enrolled in this LEAF trial. He happened to get randomized to risk factor modification and liraglutide, and he was planning to have his ablation in September 2019. But let's look what happened. So here we plot his weights. He started out at about 96 kilos. And you can see 3 months later, he lost about 9 kilograms. And at this point, when he was about to have his ablation, he turned to me and he said, listen, I don't have any more symptoms of my atrial fibrillation. Do I still need to have my ablation? So I said, okay, well, let's see. Let's do a monitor and see if you're having any atrial fibrillation. And we did a monitor, and he was not having any more atrial fibrillation. We monitored him a year later, still no atrial fibrillation. His atrial fibrillation disappeared just with weight loss, no ablation. Now, this is a dramatic example. This doesn't happen to everybody, but I think it just shows the power of weight loss in controlling atrial fibrillation. So I'd like to spend a few minutes talking about some of the other issues related to atrial fibrillation. So the first is stroke prediction in atrial fibrillation. So we have what we call is a risk score. It's called the CHA2DS2-VASc score. And it's very simple. It basically quantifies whether a patient has heart failure, high blood pressure, their age is over 75, whether they have diabetes, prior stroke, vascular disease, age 65 to 74, or whether they're female, and assigns them points based on this. So I'll give you an example of how this might work. So imagine you have a 70-year-old fit male whose doctor first diagnosed mild hypertension last year, continues to run 6 miles a day, so he's a pretty healthy person, but he's 70 years old. So he gets a point over here. He has high blood pressure, so he gets a point over here. So risk score is 2. But I want to show you now why this risk score does not work very well, because I want you to consider this person's cousin, who's 70-year-old obese male, 25-year history of hypertension, requiring multiple drugs, and never exercise. Now, if we calculate this person's risk score, he gets 1 point for being 70 and 1 point for being hypertensive, having high blood pressure. That's a risk score of 2. So this person has the same risk score as this person. Now, I ask you, is it likely that these two people really have the same risk of stroke from atrial fibrillation? I don't think so, but that's what our risk score says. And this slide shows you why that's the case. So this lists a couple of risk scores, but we're just going to look down here at the CHA2DS2-VASc score, which we just looked at. And this number called the C statistic just tells you the probability that the test is correct. And you can see the probability that the test is correct is only 0.6. So 0.6 is just marginally better than a coin toss, because the coin toss will be correct 50% of the time. So it would have a C statistic of 0.5. And that's why our risk scores really don't work so well. To highlight this even more, if we break down the patients with different risk scores, see here the overall risk of having a stroke related to the risk scores. But if we conglomerate this group over here, which accounts for 89% of all patients with atrial fibrillation, so the vast majority, and we figure out what the average risk of having a stroke is in these patients, it's 4.5%. So what that means is that 95% of patients, all of whom are going to get treated with blood thinners, aren't going to have a stroke with AFib, even if they don't get treated with blood thinners. So that's why we don't get it right all the time, because the risk of stroke is still, even though it's significant, it's still pretty low. So how can we do better? So part of the problem is that the risk score is based on things that have really nothing to do with that etiology for stroke, which is forming blood clots inside the heart. How can we look better inside the heart to see if somebody has the risk, the issues that are going to lead to blood clots forming. So in other words, slow blood flow. So we are working on developing a technique that will do that. This is based on work with colleagues at Northwestern. And this is using something called 4D flow MRI. And I'll play you a movie here that will show you basically the blood flow in the whole atrium. And then you'll see down here is color-coded the velocity or the speed of the blood flow. So you can see the individual blood flow, but you can see we can actually measure the blood flow velocity. So if a patient has low blood flow, we can actually measure that. And we think that if we can measure this low blood flow in patients with atrial fibrillation, we can identify those people who are at substantial risk for developing blood clots and stroke and atrial fibrillation. We will hopefully be studying this in a trial that we are going to be doing in conjunction with colleagues at Northwestern, University of Chicago, and Mayo Clinic. And we'll keep you posted on whether that's going to start. And hopefully we'll be able to move this technology forward for the assessment of stroke risk in atrial fibrillation. I don't want to leave without touching on ablation for atrial fibrillation, because that's also a very, very important therapy and has a lot of promise. What I'm showing you here is a little snippet of what the signals look like in atrial fibrillation when we put our catheters inside the heart. And we can put them in different locations inside the heart. And you can see when we put them in different locations, the signals all look different. And they look different to you, they look different to us. And the problem for electrophysiologists is we don't have really a good way to characterize these signals and decide which locations are really important for ablation. And what we've come up with is a way to characterize these signals and hopefully decide which signals are important for ablation. What we do is we look at the morphology of the signals and we build these plots called morphology recurrence plots that identify when the signals are very similar. So in the red, it shows the signals that are very similar to each other. Whereas here, you can see the signals are clearly varying a lot, and you don't have as much red, and you have a lot of green. And by quantifying the similarity of the signals, we can identify the hot spots, the red spots, and we're hoping that this will help us identify where we need to do the ablation. We are going to be beginning a trial to test out this new mapping technique, and this will only be being done at the University of Miami. So I'd like to obviously highlight my colleagues in the Center for Atrial Fibrillation. So these are my clinical colleagues, the physicians and nurse practitioners that work with us and run our risk factor modification program. They are all talented individuals that really have helped us improve our outcomes in atrial fibrillation. In addition to the clinical colleagues, we have a whole research team that really helps us advancing the trials and to develop the innovations that we have and have them available for you as patients in the Center for Atrial Fibrillation. So I'd like to sum up and really discuss what our challenges are for the future. I think it's really important that we highlight that atrial fibrillation therapies have to be personalized. Atrial fibrillation is a complex disease, and no two patients have the same problem in atrial fibrillation. So we really have to personalize the approach, and doing this in a Center for Atrial Fibrillation, I think, is the most viable way to be able to make sure that we do this. I think I highlighted to you very strongly the importance of risk factor modification in the treatment of atrial fibrillation. I think this has to become part and parcel of any treatment program for atrial fibrillation. We need to improve our ablation approaches. 50% success rates for persistent atrial fibrillation are not adequate. And our testing for the morphology recurrence plot mapping is in progress. And we hope that that will certainly be one of the ways that we can improve ablation. We also have to think about other novel approaches. medicines that can prevent fibrosis or diminish fibrosis, medicines that can prevent or diminish inflammation. These are important factors that lead to atrial fibrillation, and we need to figure out new ways to treat those. We need better prediction of stroke and deciding who needs to be treated, who needs to be on anticoagulants. It's not adequate to say we should treat 95% of people who aren't going to have a stroke with anticoagulants because there is a significant risk of bleeding. So we have to do better than how we're doing now. And finally, one issue which we haven't discussed, which is very, very important, is if we know that 25% of us are going to develop atrial fibrillation during our lifetime, how do we prevent that? How do we reduce that risk to 10% or 5% instead of 25%? We have to be smart about prevention, and we haven't even begun to approach that. So with that summary, I'd like to thank you for your attention. I'll be happy to address your questions.
Thank you, Dr. Goldberger. Super informative. You've covered all the bases. And before we launch into all the Q&A session, which the 200 people who are tuning in and joining us this evening are so curious to get some of these responses. So to me, listening to the whole presentation, it occurs to me that this whole conversation that the nation has launched into about Ozempic and all these drugs for weight loss, if ever there was an appropriate medical usage of it for people in the lifestyle issues of obesity, this would be the one.
Yes, you are 100% correct. So in our LEAF study, we haven't gotten all our final follow-up yet, so I don't have final results. Obviously, I've shown you the data that suggests that weight loss is certainly very important in improving the outcomes in patients with atrial fibrillation. We do not yet know whether the observations that we saw are due specifically to weight loss or to the treatment with the liraglutide, or both. We will learn that in the next coming months, and certainly if the liraglutide serves as a major factor in the improvement of the outcomes from atrial fibrillation ablation, that opens up that whole class, what they're called GLP-1 agonists, which include Ozempic, Wegovy, for treatment specifically for patients with atrial fibrillation.
Yeah, fascinating. A lot of the questions coming over, of course, have to do with ablation. Because like you said in your presentation, it is sort of the treatment for the moment, although surprisingly only 50% effective in some of these cases. So let's put it out there for people that need it. Is it safe and is it recommended in many or most cases?
So again, it's a very individualized decision. There are patients in whom atrial fibrillation is ideal, in whom atrial fibrillation is more beneficial than others. So for example, in patients with heart failure, it's been shown to be very beneficial. In younger patients, it tends to be very beneficial. In symptomatic patients, it's very beneficial. Now, that's not to say that patients who don't have symptoms or who don't fit those other categories, it's not helpful. But I think that's where the discussion between the physician and the patient is very important in the shared decision-making about whether to proceed with ablation. The procedures are overall very, very safe. Doesn't mean that there aren't a small risk of complications. Anytime one does a cardiac procedure, there has to be a discussion about those potential risks, but they are small.
Let's talk about COVID, the elephant in the room. When the pandemic took over, I'm sure you saw a great deal of cases that caused AFib. Talk about that.
Yeah, so COVID is a infection that certainly has a tropism for the heart. So that's one important factor. But the truth is, any viral infection can have effects on the hearts. It's been shown, for example, that flu also increases the incidence of atrial fibrillation. So when one certainly can see, when we did see an increase in atrial fibrillation in relation to COVID. And that has two potential etiologies. So one is a direct effect of the infection on the heart. If it's just specifically that infection on the heart that led to the atrial fibrillation, when the infection goes away, that risk of atrial fibrillation goes away. But there are some people who have an underlying propensity to atrial fibrillation, and the infection, the COVID or any viral infection, basically brings out that propensity. In which case, if the atrial fibrillation persists after that infection, it's due to that underlying propensity more than it is the infection. So there really are two different kinds of scenarios in which that COVID or any viral infection can affect the heart and atrial fibrillation.
There's a question out there tonight about the COVID booster, the booster vaccine. Can that be bad for a person with AFib?
So I would say, everything in medicine is always weighing the risks and the benefits. And there's no question that there have been identified a very, very small risk of cardiac effects due to the vaccine. But the effects of the COVID infection on the heart are many, many more fold greater. So overall, the protection that you get from the vaccine is actually going to be much better for you than the small risk that you take from having the vaccine.
Okay, well said. Here's a question. What is the underlying etiology of AFib, and are there any potential cures in the horizon? The C word, the cures.
Yeah, so in terms of the etiology, there are many, many different etiologies. So the most common etiology that we have identified, for example, is high blood pressure. So high blood pressure leads to high pressures inside the heart. It puts a load on the atrium, and that can lead to atrial fibrillation. But any heart disease can do that. So if you have a leaky valve, that can lead to atrial fibrillation. Obesity is a huge risk factor for the development of atrial fibrillation. And not all of these etiologies lead to atrial fibrillation in the same way. So atrial fibrillation is not one disease. Atrial fibrillation is sort of like a syndrome. And if you want to know the cure, you have to know what the cause is. And I think that's where we're still struggling. And that's where I think some of these newer treatments down the road, things that are targeting either inflammation that can lead to fibrosis, or antifibrotic therapies that can actually get rid of the fibrosis that occurs in the atrium, might actually help with cures.
Here's a question. I guess this patient was listening intently to your presentation. How can a patient participate in the 4D flow MRI study?
So we are not yet funded for that study, so hopefully we will be in the future. The 4D flow study that we are going to be doing, because it's very important for us to demonstrate that the 4D flow MRI is effective in predicting stroke in patients with atrial fibrillation. So the first population of patients that we're going to be studying to actually prove that are patients who've had strokes, but we don't know why they've had a stroke. A certain percentage of those patients have stroke because of the atrial fibrillation, but we don't see the atrial fibrillation. So how are we going to assess whether it's the low flow in the heart that led to the stroke? And that's using the 4D flow MRI. So that's really our first opportunity to prove that that's really an effective way to identify stroke risk.
So I'm assuming that once you're ready to, once the funding comes in and you're ready to request patients, that this population that's tuned in tonight, because there are obviously patients of the UHealth, will be the first to have access.
Absolutely. We will certainly publicize that that study is up and running, and we'd be delighted to have anybody who's appropriate participate.
Good to know. So here's a question on what do you think of the pill in the pocket approach?
So the pill in the pocket approach is popular among many physicians and many patients. In general, I'm not a big fan of the pill in the pocket approach. Antiarrhythmic drugs can be very effective for atrial fibrillation, but the antiarrhythmic drugs have real risks also. And even though the risks are small, the risks can be very significant. I mean, we're really talking about something called proarrhythmia, so causing arrhythmias that patients didn't even have before, and they could be life-threatening arrhythmias. So from my perspective is, why expose yourself to the potential for life-threatening risk with high doses of antiarrhythmic medications when you're in an unmonitored setting? To me, it doesn't make sense, but it has been used widely, and I think it is certainly a viable treatment option.
This question came in earlier today. A person with atrial fibrillation who had a procedure last year that shocked the heart, or as we call it, the zapping, internormal beat, but at times the beat is still abnormal. And this person has been told as long as they're on Eliquis, they should be okay. We're talking about the anticoagulant blood thinning group of drugs. Do you agree with that?
So it really goes back to the issue of the things that we could get concerned about with atrial fibrillation. So we said the first thing is symptoms, the second is stroke risk, and the third is long-term outcomes. So being on Eliquis addresses the stroke risk. So it addresses one of those three, but it doesn't address the symptoms, the irregular heartbeats. What's that due to? Is that due to episodes of atrial fibrillation that are coming and going, sort of the paroxysmal atrial fibrillation? And it doesn't address the long-term outcomes. So that's where you have to have that further discussion about what kind of further evaluation to do to assess those irregular beats and what kind of treatments might be helpful.
Doctor, how about the Watchman procedure that everyone's talking about? This question came in.
Yeah, so the Watchman procedure is basically a device that's put in to plug what's called the left atrial appendage, which is a piece of the left atrium that forms like a little pocket. And it turns out that 90% of the blood clots that form in atrial fibrillation form in this left atrial appendage. So the Watchman device basically addresses 90% of the blood clots, but it doesn't address all of them. It only addresses 90%. So the way I look at it is our blood thinners, which address all of the blood clots, is our best treatment for atrial fibrillation. For patients who cannot tolerate blood thinners, they can't take them, they need an alternative. And our second best treatment is the Watchman.
How many ablations are too many? How many do you have? This 74-year-old patient says has had it 5 years ago and is now back into AFib. He's 74 years old and, has regular exercise, keeps his weight down. What should he do?
Yeah, so that's a very good question. There are risks to multiple and extensive atrial fibrillation ablations. So one can ablate enough of the upper chambers of the heart, of the atria, so there's not enough muscle tissue left, and you get just fibrosis, and that leads to what we call a stiff left atrial syndrome. So you do want to be careful about multiple and extensive ablations. However, having said that, I mean, we have seen patients who've had multiple ablations elsewhere and then come to us, and we may be doing their fourth or fifth ablation, and then they still have successful results. So
I'm wondering, is there an average of how long a quote-unquote successful ablation should last?
Yeah, so that's a very good question. I think for the most part, many of our patients when they have a successful ablation, it lasts for many years. But I will tell you that we do see patients who've had successful ablations for 4 or 5 years and then have another episode of atrial fibrillation. But when that happens, you have to ask yourself, is it the same atrial fibrillation that we ablated initially, or might it be a different etiology? Because remember, I said not all AFib is the same. So can the same patient have 2 different kinds of atrial fibrillation? So I think that's probably the explanation for people who have very late recurrences of atrial fibrillation.
Here's an interesting one. There are all sorts of new wearable technologies such as Apple Watch. If that identifies AFib and cardiograms don't show, what are the next steps?
Yeah, so the Apple Watch and the cardio device, I mean, we have many, many patients who use that and many patients who do find atrial fibrillation based on their watches. And remember, I said a lot of patients don't have any symptoms with their atrial fibrillation. So screening for atrial fibrillation is a very prominent area of investigation. I mean, who should we screen? How should we screen? But certainly if a patient identifies that they have atrial fibrillation, that's something that should be investigated further and perhaps treated.
Doc, is there any correlation between this irregular heartbeat or arrhythmia and vascular headaches or migraines this particular person's concerned?
Yeah, so there's no direct correlation, except to say anything that leads to stress, it leads to adrenaline release. So adrenaline effects on the heart, are very prominent. I mean, adrenaline can certainly lead to atrial fibrillation. So I would say it's more the other direction.
We, of course, are talking about lifestyle modification, exercise, keeping your weight down, all that. Now, this person asks, can AFib be caused by very strenuous, heavy weightlifting and intense cardio? That's the antithesis of the message we want to get out, but could it?
So there are reports of, yes, very intense exercise and even athletes who develop atrial fibrillation. So what happens when people are very, very highly trained athletes, their nervous system responds to the training in such a way that they have, there are two parts of the nervous system that affect the heart, what's called the sympathetic nervous system or the adrenaline response, and the other response which slows the heart rate, which is called the parasympathetic response or the vagal response. And there's an entity called vagally mediated atrial fibrillation. So yeah, that's another etiology of atrial fibrillation. I think it's an uncommon enough problem, and most of us are not trained endurance athletes that we have to worry about it. But it is an observation. Mm-hmm. Absolutely.
Fascinating. Now, that's one I learned tonight. Question. I'm in persistent AFib and my doctor wants me to take Ticasine. I've had 3 ablations and I'm wondering if there's another option.
So Ticasine is one of the antiarrhythmic medications that's used to treat atrial fibrillation. There are a whole host of antiarrhythmic medications that we use for atrial fibrillation. There are what we call type 1C antiarrhythmic agents, called things like flecainide or Tambacor. There's other agents called Multaq or dronedarone. All these agents, one has to decide which is most appropriate for the patient. There's also a medicine called amiodarone, cortisone. It's probably the most powerful antiarrhythmic medication that we have for treatment of atrial fibrillation. However, it's also the most toxic. It can cause inflammation in the lungs, thyroid problems, liver problems. So we try to use that judiciously and not unless we really need to in patients with atrial fibrillation. So all these things have to be weighed in terms of the decision for use of antiarrhythmic medications, and weigh those in terms of the other option, which is another either catheter ablation or surgical ablation procedure.
Have you heard anything about magnesium supplements for AFib treatment?
Yeah, so there's no evidence that has any benefit for atrial fibrillation. But having said that, as with many things in medicine, there's a lot of inter-individual variations. So if somebody has what we call paroxysmal atrial fibrillation, where it comes and goes, and they tell me that when they take magnesium supplements, it goes away, I believe it. I mean, it's possible. But when you look at large groups of patients, we don't see any significant benefit.
We still have questions coming in, and we'd like to field as many as possible. Let's see what else just came here. I mean, a lot of them are ablation. Clearly, that's the concern here for either newly diagnosed or someone with a persistent issue. But here's an interesting one on what is the role of alcohol in relation to AFib. And now everybody has paid attention suddenly to this, and how much is too much alcohol, moderation, etc.
Yeah. So the truth is, even small amounts of alcohol can precipitate atrial fibrillation. There is a nice study that came out within the last couple of years from the University of California in San Francisco, where they used a transdermal monitor to measure alcohol levels and atrial fibrillation. And they found that even small increases in your blood alcohol level can be associated with atrial fibrillation. So we certainly advise abstinence if possible, and if not, very small amounts in patients with atrial fibrillation.
I wonder if the relationship or the correlation is also that alcohol increases blood pressure or hypertension. Could that be some of the reason?
Well, we don't know the exact mechanism. That's, I guess, a potential mechanism, but there are a lot of things. I mean, exercise, for example, increases your blood pressure too. So I would have to leave this one and say we really don't know exactly how it happens, but we know that there's definitely an association.
I think this is the final question that we're going to have before I ask you to wrap up, because this has been fascinating and clearly everyone's hanging on the edge learning. But what should a person do when they're having an episode of atrial fibrillation? Is there a way to just shorten the duration? This is kind of fascinating, that question.
Yeah, so that's a really tough question, and it's again very variable. A lot of patients begin to learn what their pattern is for atrial fibrillation. So there are some people who have an episode of atrial fibrillation, and when it comes, it doesn't go away, and they need some sort of definitive treatment, like the cardioversion or zapping procedure, to get them out of it. But there are a lot of people who have what we call paroxysmal atrial fibrillation, where it comes and goes. And some people have episodes that last for a minute. Some people have episodes that last for an hour. Some people have episodes that last for a couple days. And I think it depends on what each patient's pattern is, because usually the patterns are pretty predictable for patients. It's not to say that you won't see a break in the pattern, but they're usually pretty predictable. And there is really nothing per se to do about this. There are pill-in-the-pocket approaches, as we talked about earlier, that can terminate episodes of atrial fibrillation. But mostly it's a matter of knowing what your own pattern is.
Yeah. Easier said than done to relax into it, right? I can't imagine that you could, but so just in conclusion, Doc, if you could give us a couple of statements as to, as much as we know about atrial fibrillation is as little as we know, So I wonder what the take-home message is for the 200 people tuning in tonight.
Yeah, so thank you for the opportunity to summarize here. So I think it's really important to highlight that atrial fibrillation is a complex disease. It's not one disease, it's many diseases. It's multifactorial. And because of that, what's really important is that one develops a comprehensive approach. It's not only ablation, it's not only medications, it's a combination of things that need to be addressed for the patients with atrial fibrillation. And as I said in the title of my talk, it's really important to develop a good partnership, physician-patient partnership in treating the atrial fibrillation. I know there's a lot of interest in ablation. Ablation is a wonderful treatment for atrial fibrillation. I don't want to mislead people to saying that ablation successes are only 50%. 50% is sort of the average reported for persistent atrial fibrillation. For paroxysmal atrial fibrillation, our success rates are in excess of 80%. So that's for the atrial fibrillation that comes and goes. And even for persistent atrial fibrillation, our success rates are around 60%. So a little better than what's reported out there in the literature. So it's an important and available treatment options, but it's not, you can't use it in isolation. It's really important to tie that very strongly to the risk factor modification and the physician-patient partnership to help improve outcomes in atrial fibrillation.
And I think you also very modestly forget to talk about how UHealth and your program is a leader in this area. And, go ahead and do your elevator speech on that, because we are very fortunate to have this in our backyard.
Yeah, thank you for that, Ileana. Yes, I will agree. I think we have really a very unique approach and perspective to atrial fibrillation, and we're trying to teach the world that that's the approach that they should have as well. Hopefully, one day we will not be the only people doing this, but we will teach everybody that this is the proper way to go.
Well, Dr. Goldberger, we thank you so much for the privilege of your time tonight. You've been very generous with your time and your availability to all these people who are interested. And thank you to the interactive audience tonight for participating, because we at the University of Miami Health System appreciate your participation in these UMiami Health Talks. Please visit uhealthcv.com for more information. Call 305-243-5554 to make an appointment, and finish the survey at the end to give us more feedback. Thanks again, Dr. Goldberger.
Thank you, Ileana. It's wonderful being with you.
Always a pleasure. Everyone, good night. Have a great night. Stay dry in the storms, and please stay healthy. Take care.
Take care.